Hi, everybody. Welcome to Taylor Tuesday, coming to you live from Whitefish, Montana. I'm Dr. Ira Kraus. For those of you who don't know me, I know I'm fairly new to this profession, and it's very possible you don't know who I am. I'm joined by a very, very dear friend of mine, Dr. Mike King, who's going to help me moderate this program. And we are joined by our guest speaker, Dr. Amish Andy Bhatia, who has been very, very well known in the educational and in the wound care space. And we have Nathan Lavelle, the national sales manager for MPM Medical, which was one of Taylor Medical's first vendors that we signed on, and they have been a stalwart with our members, and they came through when PPP happened. That's who a lot of people are getting your masks from. So Nathan's really been fantastic and has been very loyal to Taylor, and we've been the same way back. I am going to turn it over to my cohort, Dr. Mike King, and I'm going to let him take it from here.
Super. Thanks, Ira. So for those of you who are with us all the time, you hear this a lot. For any of those who have not been, welcome to Taylor Tuesday. This is, I don't know, Ira 15th, 16th in a series. We've been doing it. So we're excited to have you here. Double so if you're new, we know we see our similar, Ira and I see our similar question people each week, which is wonderful. But if you want to take a look at this webinar after the fact, you can go to our website, taylormedical.com, and follow the link at the top toward the right-hand side. You can see the little arrows in the picture here, and you can actually look for webinars. You can go back and look at any of the past. We've had some really good ones last week. Dr. Lehrman and I and Ira did one on coding issues, and we've had just a plethora of really exciting kind of stuff. So feel free to go back, peruse, take a look at our webinars. It's exciting. So let's remind you again, if you haven't done this already, go to the Taylor website and take a look at what we can offer for you. The cool part is, for those of you who don't know, is that Taylor is free, number one. That's the best part. Number two is you can get discounts on your products. And, you know, one of the great products that has been super loyal to Taylor as a platform is noted here tonight from MPM Medical and Nathan's group. So you can go in and compare those things you've been spending a lot of money on. Send us vendors and your items that you're buying, your manufacturers. If you got the SKUs, it'd be great. The sizes, 1 gram of collagen powder, 19 grams, whatever the size is going to be. And you can compare and see the great price that Nathan's company can offer for you on those products. And what you're paying also, so that Carla and her team can give you a great review. So take a look, go to this. You can email that spreadsheet to add, or you can visit the website and you can see the link that's here too. But it's pretty easy, relatively self-explanatory when you get on there. And if you can't work in Excel, which many of us have a hard time with, it's okay. Just send a copy of recent receipts and we'll handle that. I tell people all the time now, I'm getting used to using Excel because the company I work for, my boss is without an direction in which stall to use. So it's a different world out there. Anyway, we're really tickled tonight to have a very good friend here. Number one, from a supplier standpoint, Nathan and MPM Medical is helping sponsor, been very loyal medical. But we're very fortunate. Andy Bhatia. Andy's got a plethora of accolades here. He's a past president of OFAMA, so president of the Ohio Association. He's the CAC rep in Ohio, so he's obviously got a great connection to the Medicare world. He's been a chair of the APMA coding committee. There's a proud small alumni society, Andy, that we belong to there. He is currently the president of the American Academy of Podiatric Practice Management. He's a diplomat in the American Board of Wound Management, and he's the director of our Department of Wound Care here at Taylor Medical. So, Andy, without further ado, we're going to pass this over to you, and we'll disappear for a while and watch for questions and let you and Nathan run the show. So thanks for being with us, and let her rip.
All right. Thanks, Mike. And how you doing, Nathan?
Good, Dr. Bhatia. Thanks for joining us this evening. Appreciate it.
Thanks. And if you notice, Mike always finds a way to slip the word plethora. And then he did it twice already. So I have to see if I can match him and try to put that in. So I'll start now. Welcome, everybody. And our webinar today is Surgical Dressings A to Z, which means we'll cover a plethora of stuff. Okay, thanks for the kind introduction, Mike. And we're going to go ahead and get started. And feel free to enter your questions as we go along. And if possible, I will try to maybe address the question as I'm going through. There's a little side window here which shows the questions as they pop up. I may just try to address them as I go, so you don't have to wait till the end of the talk to type them in. And if we don't get to it during the talk, we'll get to it at the end. So just a quick disclaimer: the information that's coming forth is to the best of our knowledge and as current as possible. I did try to update all the numbers, the prices, and look through all the rules. For the most part, I can say that the information is valid in almost all the states and across the Medicare DME carriers. But there may be some slight differences and nuances in policy within your particular DME MAC. So make sure that you do verify all the policy and especially the reimbursement information that I'm going to be talking about. The reimbursement numbers, as far as what they pay for specific codes and things like that, are approximate, but they're pretty close, I would say, to being fairly accurate. I just updated it a few days ago from the website itself. And that website is right there at the bottom of the slide. It's www.dmepdac. That's the Durable Medical Equipment Pricing Data Analysis Contractor. And when you go to that website, there's a little tab below that. It's the DMECS, which is the coding system. And it's a really good website if you haven't been there. Very easily, simply laid out. And I would suggest you make yourself familiar with it. You can do searches based on manufacturer, based on a specific code, and it'll show you all the products from all the different companies that are approved. Then you can click on your state and see the reimbursement. It's very easy to use, and that goes beyond just surgical dressings here. I mean, you can check any DME, your L codes and yep. So on and so forth. So very handy website.
I think you can actually search by code, and then I believe you can search by manufacturer as well if there was a specific item that you were looking for. So just want to add that.
Yeah, you can type a manufacturer's name and it lists everything they make, right? With and with the codes. So I really like the way they've done it. And if you're doing DME in your office, as whether you're the physician or a practice administrator, whoever does the billing, I think it helps to be familiar with it. All right, so we're going to move on. And obviously, the intent of this talk is not to teach you wound care. That's not why we're here. You guys know how to do that. And so hopefully some of the stuff here is just sharing my personal experience and hopefully some refresher material here. So before I get started, I just wanted to kind of put down where this talk and what we're going to talk about, where it falls in the spectrum of what we can call in the broad sense as wound bed preparation. So I put debris as number one for obvious reasons, because in the presence of non-viable tissue, no wound is going to heal, even with the magic potion my cousin sells. So always debride the wound well, manage infection, offload for diabetic ulcers, compression for venous leg ulcers, all very important and come at the top. And then right there, next up is what we're going to be focusing on today, which is where the role of specific dressings plays in this spectrum. So we use the dressings to maintain a moist wound environment. So not too dry, not too wet. We need it sort of right in the middle there, and that's why I use the word moist. So using dressings is what we use to get to that midway point. So hydrogels for drier wounds and collagens, alginates, foams, etc. for draining wounds. And then the rest of the things I have listed there are things that should be done concurrently to while the above list is being done. So, let's not forget a good vascular workup to see the vascular status, and then the appropriate referrals, X-ray to look for osteomyelitis, a biopsy to possibly look for any neoplastic lesions. A lot of wounds, especially venous leg ulcers, can sometimes be cancerous lesions, and it's good to check that out. Diagnostic ultrasound, a great modality to use, and we can do a whole lecture on that and how to use diagnostic ultrasound in wound care to look for tunneling, especially with diabetic foot ulcers, before you do the debridement, and possibly early signs of osteomyelitis. Of course, let's not forget sending our patient out for the appropriate consults, nutrition, endocrinology, and doing the blood work. So, we can see the overall what we need to do here. And obviously, beyond this, there's advanced care such as skin substitutes, hyperbaric, wound vacs, and so on. So that's the next step if none of this works. All right, so now we're going to move on to what our talk today is focused on, which is surgical dressings. And so let's start by talking about draining wounds. And we'll keep coming back to our intent here is to bring the wound to this happy medium, which is moist. So when we have wounds that are draining, and these could be these for purposes of getting reimbursed, surgery doesn't always have to be hospital based or something like that. In fact, debridement is considered as surgery. So any full thickness wound qualifies for reimbursement for dressings. And that's why I put that up front, because we're going to be talking about reimbursement throughout the topic today. All right, so the first product I want to talk about for draining wounds is calcium alginates. And Nathan, feel free to chip in if
sure.
I missed something about this specific type of product. They're made from seaweed, very absorbent. The rules require that the wound have moderate to heavy drainage in order to get reimbursed for dispensing calcium alginates to your patient. And just like everything else, your note must reflect that. So always remember to mention the type of drainage is, serous sanguinous is, copious, things like that. And, moderate to heavy is what we need for calcium alginates. Obviously, we cannot use it with hydrogels. I just kind of threw that in there because they do the opposite thing. They're available in flat pads for open wounds. I think we've got some good photos of the product so you can see. They also come in ropes and really different form factors to now the alginate, and even with the silver combined will not treat an infected wound. So you do have to address the infection separately. But the silver in the alginates does help with biofilm management, on the surface of the ulcer, which is also very essential to assisting healing.
Dr. Bhatia, if I could just add on the calcium alginates, a rule of thumb is they'll usually hold about 4 times their weight in drainage. That's a pretty safe bet across the board. And then also, if you ever hear people talking about like hydrofiber dressings, those are similar to calcium alginates. They're not composed of the seaweed like a calcium alginate is, but they kind of fall into that same classification for insurance purposes, and then also just holding about that 4 times their weight in drainage.
So I'm not going to be talking about hydrofiber dressings today, but they do fit well in here in the category of absorbent dressings. The 2 codes I've listed here, A6196 and A6197, are the 2 basic codes that are in play here for calcium alginate dressings, and they apply to. And I've given examples there of some products here, and I think Nathan can help me also talk about some of these products. The 2x2, Excelginate, or the 4x4 Drymax, these are the size of alginates that qualify for the 6196 code, and then the A6197 is for the larger sizes, which is the 4x4.75 or 4x8 Drymax. Is that pretty accurate there, Nathan?
Yes, yep.
All right. And the next point here is a very important point. in terms of how many you can get dispensed for. How many you can dispense and get reimbursed for. So per wound, you're allowed to dispense to the patient 30 pieces per wound per month. And so that's, one dressing per day per wound is what they allow, and that's what these dressings are meant for. That's what they're fairly absorbent, and if you need greater absorption, you can probably pick a different product, but an alginate is meant to be changed once a day. So let's say we were dispensing these to a patient that comes in with a diabetic foot ulcer. You did your debridement, and they have a draining wound. You need to get some of that, or your venous leg ulcer. You need to get the drainage under control. You want to dispense X number of dressings to the patient. Now, just because 30 pieces per wound per month is the maximum allowed, it doesn't necessarily mean you have to give 30. If you feel that in a couple weeks, you may want to reassess and try different type or different category of dressing, you could only give 14 and then just bill for the 14. When they come back, if you want to continue them for another month or whatever, however long, or 2 weeks on calcium alginates, you could dispense it again and bill it again. So it doesn't always have to be the full 30. That's just the max allowed. So let's look at the difference here between your cost to you and what is going to be reimbursed per piece by the DME max. And you can read off the slide here, but you get the general idea. You can see the cost for the 2x2, 4x4 Alginates, and then the 4x4 and 4x8 dry maxes in progressive order, $276.50, and then you can see their reimbursement is, as you can see, considerably higher than the cost. I would say almost 3 to 4 times as much. And is there anything else you wanted to add about these, Nate?
Yeah, just there was a question on the side. If someone was treating 3 wounds, could they do a 30-day supply for each? And the answer is yes. So it's 30 days per wound per month, 30 dressings per wound per month. So if you had 3 wounds, you could do, you could treat each one of those individually. The other thing I'll say on calcium alginates and alginates is that there's been a lot of new dressings that have come out that have kind of, CMS didn't know really where to place them. So they kind of get thrown into the alginate category. So the dry max that you'll see, and you'll see a picture of it on the next slide, it's actually a super absorbent dressing instead of an alginate, but it absorbs like an alginate, so it gets lumped into the alginate category. So they gel as they absorb, and then they remain dry to the touch and will absorb a lot of drainage. So they're for really, really high draining wounds, but they get kind of lumped into that alginate category, and so they have to meet those same criteria to be reimbursed by insurance, that moderate to high drainage, just like an alginate. So you see the picture of the super absorbents on the bottom right there, and then the traditional calcium alginate on the top, and that's the silver version.
Okay, yeah, the AG.
Yep.
And from what I understand, the dry max comes with and without an adhesive border, correct?
Correct, you got it. Yeah, so that's kind of, you can use that as a primary dressing, which is what we're talking about, and then later on we'll talk about using an alginate as a secondary dressing. So you've got some leeway, some options on how to use an alginate.
All right. And let's talk about the next category of products here, foams, also to be used for draining wounds, and the same kind of rules apply, moderate to heavy drainage. They're also very absorbent, and also come in all kinds of form factors to be able to use for different types of wounds, whether it's on the ankle, the heel, the leg, and they're easy to mold. They can have a film, can have an adhesive within it, an adhesive border. They can have silver, so just a whole broad variety of foams out there. They are semi-occlusive, and they can also be used as filler in dead space. Most of the foams that I'm aware now are pretty good as far as not adhering to the wound bed. And this is not to be used for dry eschar. Again, for obvious reasons, because typically your dry eschar would not be draining, and this would not be an appropriate use for that. And they cannot be used with hydrogels for the same reason. All right. So similar to the calcium alginates, there's rules that apply to dispensing of foams. But a key difference here, and one that is often where mistakes are made, foams are only allowed to be dispensed 12 pieces per wound per month. So remember that. The idea behind that is the thought that foams can be left for up to 2 to 3 days on a wound and can be changed every 2 to 3 days. So you're only allowed to get reimbursed for dispensing up to 12 pieces per wound per month. Now, again, if you feel that the patient needs a foam more than one, more frequently than that, go ahead and dispense it, but you'll only get reimbursed for up to 12 pieces per wound per month. Okay, so let's keep that in mind. The cost for an example for a foam such as the 4x4 No Traum Extra. Now this one I do have experience with using, and I just love the way that it adheres on the wound molds, but it does not stick to the wound bed, and so it's really comfortable to pay to the patient at the time of dressing removal. So I do have experience with that one. And there's your cost. It's about $380 each, and then your reimbursement. The code for that is A6212. And for those of you trying to hastily write this down, as Dr. Kraus said earlier, you have access to these slides, so you'll have all this information available to you. The bigger sizes, such as the 6x6, you can see the cost is a little bit more, $590, and it reimburses more as well. The code there again is A6212. I think I believe I made an error here, right?
No, it uses the same code because it goes off of the pad size, not the overall size.
You're right. Okay, so the reimbursement is the same then, but it's still more, considerably more than the cost. Correct. Okay, so both the 4x4 and the 6x6 have the same code because of the pad size. They cost a bit different, but they reimburse $11.28, which is still
correct.
A good amount more than what they cost. All right.
The way that a lot of the codes are written for the dressings are below 16 square inches, between 16 square inches and 48 inches, and then above 48 square inches. So that 6x6 has a 4x4 pad, so it falls into that smaller pad, even though it's a 6x6 overall dressing.
Right, and I just want to be clear, the codes that we're covering here are not all the codes that are available for wound dressings. The ones I included are the most frequently used ones in podiatry based on the typical size of the wounds that we see. Now, if you happen to have larger wounds, there are codes that go beyond this. There's A6213, 6214, and so on, which cover dressing sizes that are larger. So you can find those codes on the website that I mentioned earlier. Here's a picture of the No Traum, and I guess the silicone, right, is what causes that non-stick quality.
Yeah. Yep. You have a lot of options when it comes to foam. You can get non-bordered traditional foams. You can get silicone bordered. You can get silicone without a border. You can get silver with silicone. So you have a ton of options on what you're looking for. If you don't want adhesive on the wound bed, you don't have to. If you want it to stick really well and mold to the patient's body, silicone's a good option for sure.
Great. Okay. And foams, again, can be used as secondary dressing, correct?
Correct. Yep. Primary or secondary.
All right.
And something I'll say about foams too, just a really common question that we get is, I have a patient that I'm worried about, some skin breakdown or pressure. Can I use a foam? Because foams are really good at relieving pressure, but the answer is no, you can't, dispense it and order it just for those purposes, even though it is good at that. You still have to have the open wound, unfortunately.
Sounds good. All right, and then we move on to the third product that I'm going to cover as far as draining wounds are concerned, and that is collagens. A lot of research and effort is being put into this specific category. Very exciting field. The reason is, and then you'll see as we talk about them, is their versatility in terms of usage, and then what they bring to the wound. So collagens are absorbent, they can be conformable, they're non-adherent, but they are absorbent dressings, and so your note needs to indicate mild or moderate drainage in order for collagen use to be appropriate at that time. And as I said earlier, they're so versatile because they come in pads, they can come in a particulate form, as a powder, even as a paste, a ribbon, strip. I mean, any kind of wound, you can find an appropriate collagen to use on it. You can use them in infected and tunneling wounds. And what they do is they provide a matrix there, and really the science behind what collagens do at the wound bed level is quite extensive, and can't really go into the details of that, but they play a role in angiogenesis at the wound bed level, vessel growth, and as a matrix for tissue growth. The collagens are not, however, recommended for third-degree burns, obviously not on dry eschar and on necrotic wounds. Again, as I mentioned earlier, the wounds need to be debrided and free of non-viable tissue to move on to the next level. And this specific factor I did put in for the collagens because the collagens tend to work much better in wounds that have been debrided well and have non-viable tissue. Now, the other ones, such as foams, alginates, you can use to a certain degree of effectiveness with wounds that have necrotic tissue. But for collagens to really be effective, you have to have debrided the wound well. So, sometimes you may need to bring a collagen in at a later point in the spectrum of your approach to the wound. So if you have a wound come in, it's your first visit, have a draining wound that's got necrotic tissue, you've just started debriding it, it would be appropriate to then use an alginate or foam to get that drainage under control. And you have a couple of visits down where you've got the wound cleaned up with subsequent debridements. Now you can switch to a collagen, and they do wonders at that point. So if you're dispensing collagens, there's different codes that are assigned to different form factors. I'm just going to cover a couple of the basic ones here that are most frequently used. So the A6021 is for a collagen pad less than 16 square inches. And A6023 for a collagen pad more than 48 square inches. And then we have A6010, which is for collagen powder per gram. And that's a key thing to remember, it's per gram. So the rules as far as dispensing collagen products. If you're dispensing a pad, similar to the alginates, the requirement is that you can only do a max of up to 30 pads per wound per month, up to 30. The typical cost for, let's say, a collagen like triple helix is around $650, and for the 2x2, and excuse me, I think I have. Is it 5? Is it 55 or 5.5?
55 for the larger one.
Okay, so it's $55 for the 7x7, considerably bigger one there. Is that accurate there, Nathan?
That's correct. We don't have the reimbursement values up there, but that 2x2 collagen, the reimbursement on that is in the neighborhood of about $22. And then for that larger one, the 7x7, it's about $250 that Medicare reimburses. So we have them listed elsewhere, but not there.
Okay. Yeah, I mean, I missed putting it on here. So for the 2x2, the cost is $650, and the reimbursement you said is about
$22.
22. Okay. And then for the larger size, if you do have a wound that size 7x7, you can use the larger pad, and it will cost you $55 per piece, and the reimbursement is upwards of $200, right?
Yep.
All right. Now, if you choose to use a powder instead, you could dispense up to 30 grams of powder per wound per month. So the idea is for them to use 1 gram per day. Your cost is $7 per gram, and your reimbursement is $35.98, $36 per gram. And a good example of that, again, a product that I'm quite familiar with is triple helix powder. And here are some nice pictures here, some of the products. I'll let Nathan mention something more about these.
Yeah, just please realize that within the triple helix line, we do have different forms of it. We have the sheets of various sizes. We have the powder. We do have ropes. We're not going to talk about ropes this evening because from a reimbursement standpoint, they're not covered. But the sheets and powder definitely are. Just know that they're all derived from the same material. It's all 100% pure collagen. Some common questions we get with it is, you have a sheet, you have a powder. Why would I use one over the other? I think it depends on your patient. I think it depends on your preference. They're both going to absorb quickly. They're both going to, aid the body in healing itself, but they just kind of have different properties. The powder is nice because it fits, every shape, size, and depth of wound. But the sheets are nice because sometimes they're a little bit easier to apply. So when offices utilize our collagen, they usually end up using both the powder and the sheets because they both have different niches. So unfortunately, I can't tell you that one is better than the other or one is the one you should only utilize. But just know that you have options when it comes to the triple helix collagen line.
Okay, I'm going to take a minute here to address some questions. So we have a question here. Do you have to account for wastage to Medicare for wound dressings that are larger than the wound? And do you have to somehow size the wound for Medicare? So in this case, you have a bit of leeway in terms of medical decision making. What Medicare would like and any other third-party reimbursement company would like is for you to use the most appropriate size dressing that is obviously a little bit larger than the wound. And there's so many sizes available that it's really possible to do that. But obviously, if you have a 2x2 or 2x3 wound and you're using a giant dressing, you'll have to justify that if you're ever asked or if your notes are looked at as to why you chose that, and it has to make sense. So I've been I've helped quite a few of our colleagues with audits in this department, and it's for the most part I have not seen this to be an issue that Medicare has found to be prevalent. So for the most part, everybody is picking the right size dressing. There's going to be a little bit wastage. Let's say, for example, on the powders, right? You am I correct, Nathan? You get these the powders are in the 1 gram packets, correct?
Yeah, you can get them in the 1 gram packets, or there's a 10 gram bottle as well.
Right. So, let's say you're opening a 1 gram packet for the wound for that day, and you may not need, if the wound's a little bit on the smaller size, you may not need all of it, but you've already opened the packet and the sterility is broken. You're going to have some wastage, and that's understandable. And Medicare has figured that into appropriate wound care. That's they've in fact require the dressings to be sterile. So, you have to get rid of the rest, and you don't really have to. I think the question is, do you have to size the wound for Medicare? Well, you do have to put the size of the wound in your note. That you have to do that every time, but you really don't have to explain why you chose a particular size dressing for a particular wound. It just has to make common sense. So I hope that makes sense. And then the wastage, as long as it's within reason, is not an issue. Let's say 3 wounds or 30 days. We already talked about that. Yeah, it's per wound per month. Some of our listeners did not have audio, so I hope that has fixed itself, and I hope you guys can hear me now. Whoever mentioned that they did not have audio, so please mention if you still don't, or I guess if you can't hear me, that would be a problem, but that might be already addressed. There was a question about if you have collagen for a surgical wound, like a PNA, which is a full thickness wound.
So this is a topic of a bit of controversy as far as being able to use for PNAs for the nail bed. So I'll hold that thought, and I'm going to come back to it because I think I have a slide that addresses some of these type of office-based wounds, and I'll talk about it then. But good question, and definitely a frequently asked question. Let's say, okay, I think so. We've addressed some of the main questions here, and we'll come back to some. I know we mentioned, Nathan, we did mention primary and secondary dressings. And I'll mention it quickly here, but there's another slide coming up as well. So a primary dressing, and good question, by the way, is one that goes directly onto the wound. And, you could have the alginate, you could have foam, collagen, and so forth. And the secondary dressing is what you use to keep that in place. And what goes on top, it could be gauze, cholesterol, things like that. And secondary dressings are also reimbursed. So that we will talk about. So you can dispense to the patient a primary dressing as well as a secondary dressing to keep that in place, and you will be billing for both of them. But great question, and that will be coming up as well. So we talked about draining wounds, and the other end of the spectrum, we have dry wounds. These also, we'll keep mentioning this because this is important. To be reimbursed, your wound has to be a full thickness wound, and it could be any surgically created full thickness wound, and surgery includes debridement. So in other words, what they're trying to say is that a wound should be debrided, and not just a superficial debridement, but a full thickness debridement. So the wound could already be full thickness when you see it, and then you debride it, or you could debride it and make it to the depth of a full thickness wound, and either of those would qualify to be reimbursed for dispensing dressings. So in order to bring a dry wound to that happy medium, we would use hydrogels to add moisture to the wound. And your note reflects to say that, and your note needs to reflect that there's none to light drainage. So, sometimes you could have light drainage, and so there's a middle ground there. I mean, there's some gray area that you could, for the light drainage, also use one of the absorbent dressing, or if you still think that the wound needs a bit of moisture to have that moist wound healing, you could even add a hydrogel there. So, there's quite a bit of leeway given here to the physician to make the appropriate choice as far as whatever is medically necessary. So this stuff here is not completely rigid, as long as your note just makes sense. It all has to make common sense. Hydrogels are also available in different gels, sheets. They come impregnated in gauze, and for whatever type of wound you have, and they could be used to pack wounds and all kinds of things. So again, a very versatile category and a broad range of products. Even the hydrogels now come with antimicrobials in it, and so on. Just have to be careful, where you draw the line between causing a maceration to the wound if you add too much moisture to the wound. And this is more of a case, really, if you're treating nursing home or elderly patients or patients that are bedridden or immobile, where the hydrogel could just be sitting there and cause maceration, and that would be a problem. So, just like the other products, hydrogels also have specific wound codes assigned to the different types of form factors. Each one has its appropriate reimbursement value. So just to mention a couple real quick, say if you use a saturated wound gauze with hydrogen in it, you're allowed to dispense 30 pieces per wound per month there. That's the rule. If you're giving gels, you can give up to 3 ounces per wound per month. Your typical cost there would be like, say, 50 cents for the gauze, and then the reimbursement's $5.53, and this is all per piece. If it's not mentioned there, so the reimbursement amounts are all per piece, and the code is A6231. If you're giving out a gel,
For a full 3-ounce tube for, let's say, Excel Gel is $4.25, and then your reimbursement there is $26 for the 3 ounces. And the reason I'm mentioning 3 ounces there is because that's what you're allowed to give per wound per month. All right. The code there is A6248. So just a quick correction there. I mentioned that it was $26 of the reimbursement. Apologize. It's $26 for the 3-ounce tube of Silvermed. The reimbursement is $56.64, and that is for that A6248, which is the code for the gel, 3 ounces. So a couple examples there. We have the MPM saturated gauze, the Excel Gel, which I mentioned, and Silvermed, and we got some good photos here to show you what they look like. What's the difference between the Excel Gel and Silvermed?
Yeah, so they're both aloe vera based, so they're both going to obviously hydrate the wound bed. The Silvermed on the left there, it has silver, which is nanomicrobial, so it'll kill MRSA and VRE and staph and everything that's going to cause odor in those wounds. It's going to kill all that for you. It's sulfa-free though, unlike good old standby Silvadene. So you don't have to worry about self-allergies with patients, and then you get a lot longer silver release period with some of the silver hydrogels. So Silvermed, for example, will kill bacteria for about 5 days in a wound bed. So it's important to note, because as we were just talking about, in a true hydrogel, you only get 3 ounces per month. So if you just want to use a hydrogel, you really need to make it last, especially if you've got a wound with some size. It's not pictured here, but we also have a hydrogel that has lidocaine in it. So if you ever have anybody complaining of pain, we do have one that has lidocaine as well.
Okay. And I mentioned the saturated gauze as well, and I'm not sure if there's a picture for that. No, don't have a picture of the saturated gauze, but anyway, so we're going to move on, and as promised, we will talk about secondary dressings. So these can be dispensed in addition to your primary dressing, and you can choose also here what is your preference and what the wound needs. So if you use, for example, the Drymax border, you can put this over a collagen, and I have used this for powders because the powders, it holds the powder nicely in place over a highly draining wound, especially for a wound. Venous leg ulcer is really what I've kind of had a lot of use for this. And, you're trying to put, especially with a patient, sometimes trying to put it. So I have them put the powder actually on the Drymax itself, and then quickly put it on to the venous leg ulcer. It works really nicely for them at home. And these should not be used over an alginate because they kind of do the same thing, in the sense of the Drymax and the alginate. So you can use these daily, so you can use the Drymax as the secondary dressing along with your primary dressing daily. Your code for that product is A6196, and then there's your reimbursement, and these are the same codes as Alginates, if you notice, but for lack of being able to put this product in a different category, they got put in here, and you can see the reimbursement amounts. Now, if you want to use bordered gauze, which I do use quite a bit, and you could use these over collagens, alginates, hydrogels, all kinds of products, but you're not allowed to use it over foams because the foam itself can function as its own secondary dressing, correct? So that would be sort of repeating again. So if you see the common sense here that they're going by, if you're using a foam, you really don't need bordered gauze over it because they have an adhesive border. You can use one, or they sometimes adhere by themselves. The code is A6219, and then your cost and reimbursement amounts are mentioned there. And I also mentioned about foams that can be used as secondary dressings. So here are a couple of photos of the Drymax bordered. Is this the same one that we had earlier, Nathan?
Yeah, yep, that was the same one we were talking about. I take that back, actually. We had pictures of the non-bordered one,
Okay.
and this is a picture of the bordered one.
All right, sounds good. There's the wound guard, the bordered gauze. Okay. Was there anything else you wanted to mention about secondary dressings, Nathan, before we go on?
I would just say that, know that you have options depending on, how often you want the patient changing their dressing, how much drainage there is, and then, what your primary dressing is. So, but just know that you're not stuck. You just know that you can't only use bordered gauze, or you have to use a foam or something like that. You do have options when it comes to secondary dressings. And the whole alginate as a secondary dressing, that's kind of new. So if you learned this stuff a long time ago, that might be a little bit new to you, but that's becoming more and more commonplace, especially because you can change alginates daily, so you can get 30 of them.
All right. Thank you. All right, so let's talk about some of the billing documentation and compliance requirements. I've kind of been throwing this along the way as well. So, like I mentioned, the wound needs to have been debrided and needs to be a full thickness wound. Some of the things that you should have in your progress note. Now, this is just specific to what needs to be in there if you're dispensing products. Obviously, in your progress note about the wound, you need to have all the other stuff, your description of the wound and all the details about the wound and your history and all that. But these are the things that should be there if you are dispensing surgical dressings that visit. So make sure you have the type of wound, the necrotic tissue presence. Again, why? Because as we talked about before, there's certain requirements as far as, what dressings you can give for what type of wound. So that's why your description needs to be detailed. Size and depth, amount of drainage, did you debride, what did you use, and then the depth of your debridement. And finally, at the end, you can mention what dressings you applied. Of course, you don't bill for those, and then what you dispensed. What's your plan? Why did you? Some of the reasoning should be there, right? I mean, you have a draining wound. Okay, we dispensed a collagen powder to be used for X number of days, and the appropriate dressings, primary and secondary, were dispensed. So a nice comprehensive note. Doesn't have to be, overly thorough, but if you use this as a checklist here for your EMR template, you should be in good shape. So in your plan, I kind of made it a nice little checklist here also. In your plan section, you want to, you make sure that you hit all the points. And this really is actually could be just one sentence, right? So it's the type of dressing would be collagen. It's I dispensed collagen powder, 14 grams to be used for one wound daily. And obviously, you see I've hit all those points. And that's the reasoning, and that's what I put in my plan. And that's it. Your billing for these dressings, you put your diagnosis codes, and then you put the appropriate code for the product. You put the number that you dispense. And again, I've mentioned that website here if you need to look up any codes. So the third point, your number of dressings dispensed. So remember the maximum you're allowed. And finally, there's a modifier required. And this alludes to the question I asked earlier, if I had, if they had multiple wounds, like 3 wounds, and you're dispensing, X number of products. So you have to put the modifier A, and then followed by the number of wounds that you are dispensing for. So A1, A2, A3, A4, up to whatever, A9, to indicate how many wounds you're dispensing that for. So this A number is really important when you're doing it for multiple wounds, because that automatically with the computer system sets the maximum allowed. So A2, A3, A4, that sets the maximum allowed to be dispensed. All right, so there is your A modifier. Okay, it goes in box 24D. Okay, so this was a question earlier about using it in certain office-based wounds, like a matrixectomy, PNA, punch biopsies, verruca, and IND of abscesses. So these are wounds that could be actually created in the office as part of a surgical procedure. But, it has to be a full thickness wounds. And we know that all matrixectomies don't necessarily result in a full thickness wound. So we have to be careful there. If it's severe enough and your procedure did result in a full thickness draining or dry wound, then you can dispense surgical dressings, punch biopsy, debridement of verruca, and similarly, all the same rule applies. Any of these procedures, these are things that you do in the office. If any of these, doesn't have to be all of them, and it's probably common sense that it's not every time, the occasions where these procedures do result in a full thickness wound, then it is appropriate to dispense these dressings. We mentioned that we have primary, secondary dressing, and so on and so forth, and the patient probably needs a cleanser of some sort. So to make it easy now, we have these kits that are available, and they include a cleanser in it and roll gauze and stuff. There's no billing code for the wound cleanser, but the kits come in, and I believe with a discounted cost, and then you can bill for whatever products are included in that kit. So it kind of makes it easier for the practice, also makes it easy for the patient to just take something with them. And an example here is a collagen powder kit for daily dressing changes. And I think Nathan can mention a little bit more about that.
Yeah, so we give you the reimbursement or costs there. So that 15-day kit, just to give you an idea, that would cost about $140, and it would reimburse about $556. And then you see the 30-day kit below it, it costs you about $270, and it reimburse a little over $1,100. So what we're trying to do with the kits is, give you something that's, easy for your patients to use at home. They don't have a ton of dressings showing up and a ton of dressings to choose from or anything like that. It has a wound cleanser, it has a primary dressing, and then it has a secondary dressing. So it's easy for them to use at home. And then from your standpoint, it's easy from a billing and compliance standpoint, because all the products that we package in these kits, they all go together from a billing standpoint. And then you're only having to worry about 2 codes. And we supply you with that coding, so you know what the codes for the products in the kits is. And so there's no questions there. And if I'll flip over to the next slide here, kind of give you an idea. When we first started with Taylor, we had just collagen powder kits and collagen sheet kits, and we've kind of expanded that over the years. So you kind of see some of them pictured here. We have alginate kits, silver alginate kits, foam kits, all the different types of foams. If you want silicone foam, you can get that. And then what we've done is we've kind of customized kits for practices. We have some practices that like collagen powder, but they really like foams. So we make a kit for them that way. Or we recently did one for a practice in Pittsburgh where they really like ABD pads. They like collagen powder, ABD pads, and then they wanted roll gauze. So we packaged a kit for them together like that. So we have a bunch of them that are ready to go, packaged appropriately. And then, I guess what I'm saying is if there's certain things you like that that you want us to package together into a kit for you, we can always do that too. But again, what we're really trying to do is just make something easy for your patient to use at home, and then easy from a reimbursement standpoint.
And you can, really see here, not that we need to focus on the financial aspect, but just something that struck my mind here. I mean, as long as you're doing the right thing for the right patient and dispensing appropriately. Really, if you're dispensing 1 or 2 kits a week, which is not within the realm of possibility, you're looking at adding about $30,000 to $40,000 of revenue to your practice while doing what's appropriate for the patient. So it does add up. As I mentioned earlier, the cleanser cannot be billed to your insurance. The cost is $4, and really at the levels that we're being reimbursed. In my practice, we just include it and we don't charge the patient. But if you want to charge the patient additional for the wound cleanser, you're certainly able to do so. So to wrap things up, I believe this is my final slide. Yes. All right. So to wrap things up, just stuff that I've already covered. Make sure you know the indications and applications, because that's what will hurt you if you do get audited and if they look at it. The product has to match the type of wound that you're using it for, and the length of treatment that you're using it for, because there's also no restrictions as far as how long you can use these products. So some of these wounds do last a long time before they get healed, 2-3 months. But if you look at your notes and look that you're just continually just dispensing dressings, the same one for the same type of dressing for 3, 4, 5, 6 months, and these are some of the things I've seen, then it doesn't make sense, because if you look at the note after note and it says the wound's not really improving, yet you continue to dispense the same dressing. Well, what's the end goal here? Why didn't you switch the product? Why didn't you try something else? Whatever, wound vac, hyperbaric, something else. So at the end of the day, it has to be good medicine, and as long as we do that, there should not be a problem here. Make sure you have your shelf life, and most of these products really do last a very long time. And then the cost of the product is something to know, but if you do it right, the net to your practice is substantial, because the reimbursement, as you can see, is several multiples of the cost. The website I've given you now a couple of times. Please make yourself familiar. Know the frequency allowed, like 12. 12 foams per wound per month, and so on. I give you the codes, and then of course, like I said, your documentation. So remember, this is durable medical equipment, right? And if you do other durable medical equipment like diabetic shoes, cam walkers, crutches, they all have that universal documentation requirement, which is that you have to have the patient sign for what they received. So you could really use the same form that you use for the other products, and you could have a checkbox as for what you dispense real quick, but the patient has to sign what is, I guess, known as the proof of delivery. Okay, and then on the back of that, you could have a pre-printed the supplier standards, which is required. I did mention instructions on here, but really all of these products now come with instructions in the box and in the kit. So it doesn't have to be a separate thing. Your progress note should be good, and then your dispense note, or your proof of delivery, what patient signs. You want to put that there's a warranty that if the products are defective, that you will replace them. One important thing I want to mention here: if you have a patient that is on a Part A stay, which is a short-term stay in a nursing home, this is their first 100 days after they're released from a hospital stay, or if they're on hospice or under home health care, you are not allowed to dispense dressings and get reimbursed, because it's the responsibility of those entities to provide the dressings, such as the nursing home, the hospice agency, or the home health care. So if you're in an office and you have patients that are homebound primarily, but coming from a nursing home or hospice, it's important for you to ask these questions, because if they do have any of these services, then you could just write a prescription for the product, and that entity has to provide the surgical dressings, the home health agency or the nursing home or the hospice company. So at that point, it's out of your hand. If you do dispense it to patients that have these, you will not get reimbursed, and you're out the dressings. So just be careful about that. So that concludes it. And Nathan, any thing you want to add? And then we're going to hit
I would just add, I know that proof of delivery is very important. So I'll just add that on our end, if you ever want to use any of our stuff, we have pre-made up sheets that have our products on them, and you can use, to have your patient sign. You can check off, what you gave them. And then back to those kits, you can have the kits in your office, or we can send them directly to your patients. If we do that, we will supply you with the tracking number. We ship FedEx, and then we'll supply you with actual proof of delivery that you can keep on file. So if you ever do need to prove that it actually got to the patient, you can prove that. So we supply that for you as well.
Great, thanks. I'm going to hit a question real quick. A good question here from a fellow Ohioan. way to go. And I think I missed mentioning that when I was talking about wounds that you see in the office. The question is, do you have any experience in billing these products with post-surgical wounds such as bunionectomies? And the answer is yes. And you are able to dispense it. So that's, if you have a surgical practice, don't think you can't do it. So you don't always have to think of these as wound dressings. In fact, the title is surgical dressings. So if you don't have a wound heavy practice, you have surgical practice, you can do this. If you have patients coming in post bunionectomies or any other rear foot, forefoot procedures, and these are surgically created wounds. So you can give the appropriate dressing, just like any of these other wounds that we mentioned. It does not have to be a chronic wound. So the same rules apply: dry wound, a draining wound, and then the dressing. So whether it's a bunionectomy or anything else, you can go in and do that. Okay. Any other questions there, Mike or Ira? Anything I've missed?
Yeah, actually, Andy, there's a couple of good ones, and we're already over our time, so we'll speed it up here. But this is still, there's some great questions here too. How would you compare this to, like, one of the more common things out there is Amerigel, that people just know about it, and I think they're getting to know about Nathan's product as well. How would you compare? Are they synonymous types of products?
I don't know if the question was specifically at, yep, it was for hydrogel. So yeah, so the Excel gel that was pictured a couple slides back, that would be our hydrogel that would kind of compete with the Amerigel wound gel. It does not have oaken in it, but ours has something called benzethonium chloride in it. So it will kill bacteria, and we can make that claim just like Amerigel can with the oaken. So.
And
super. And I know
these questions
Andy,
out. Yes, go ahead.
So Andy, most of these are passed, which is great, which makes it easy. So a couple of the questions talk about Blue Shields and Medicare Advantage plans. How do you deal with those?
The same rules apply, but you do have to check with the company whether you're allowed to dispense it. So before you start doing this for Medicare Advantage plans or commercial plans, make sure you check their fee schedules, because it does not have to match Medicare. So don't think that the reimbursement amounts that I've mentioned here will be the same with either Medicare Advantage plans or with your commercial plans. So even if they do reimburse, their reimbursement could be quite a bit low. So you may want to think about that. So ask about that. Sometimes these plans also only require that they get the product from a specific DMA supplier. So you may not even be allowed at all. So you have to find that out. And the question here is if it's available, the kits are available through Taylor. Yes, they are. Let's say PNA or wart. It says here, if the wound is it draining or not draining the day of the procedure, how can you document draining? You can. I mentioned that the wound is anticipated to be heavily draining. So because anyhow, if you're doing a procedure, you're applying a dressing on it at that time. So any product that you're going to give them will only be used the following day. So if you're anticipating a heavily draining wound, and it is appropriate to mention that in your note that it's anticipated to drain, and that's why you give that particular product. Let's see, what insurance pays for this? Again, we went over that. Apart from Medicare, anything else you have to check and make sure. For Medicare Advantage plans, do you have to get prior approval? The answer is yes. It says, do you have to use the cheapest dressing first? And will you be questioned as to why you went for a more expensive dressing first? That is not the case. You could just use whatever you think is appropriate. You are not expected to necessarily pick the cheapest one first. Just pick whatever the most appropriate is that you think for the wound, and as long as you justify at the end of your note why you picked it in terms of draining, non-draining side, and so forth, that's all that's needed. If you have a 4x4, would you need to use 4 2x2 units or one? So again, in terms of choosing the appropriate size, if you have a large wound and you pick multiple small ones, that's also okay. So if you have a large wound and you use multiple small dressings, that's okay, but then your max is going to be limited to that. So you have to decide if you want to use one large and give 30 of those, or if you're using a small one, you'll still be limited to the max amount of 30 per month. So if you're using multiple small pieces to cover a larger wound, you have to understand that your max will be, applicable in that situation. And I think that's all I have. Do we get all the questions there? Place of service for the bandages. Oh, that's a good question. Sorry. What's the place of services that you're going to put for any of these? You're going to put the place of service as home always, because they are to be used at home. Just like any DME, your place of service will be home. And no modifiers like KX or anything like that. No modifiers. The only modifier you will use is the A modifier followed by a number, which is the number of wounds you have. So a few more questions, but we're running out of time. Thank you. Lots of questions. Awesome. So hope you liked it.
Ira, you're on mute.
Let Ira and Mike take it from here.
Mode. So, Ira, we can't hear you. We want to thank everybody while he's trying to fix his technical issue. We went over a little bit, but Andy and Nate, and I know I speak for Ira since he's on mute mode, that we thank you. Everybody, you can get these products through the Tailor portal, and as Nathan alluded to, they are really very flexible in helping you design kits to fit the mode that you need for your own clinical circumstances and practice. So we're very excited. Thank you, everybody, for joining us, and we'll be on again in a couple of weeks for our next Tailor Tuesday when we have Dr. William Duke, and Ira and I will be back again, and Dr. Duke will be talking about interfill technical tips and some case studies. So we thank all of you very much. Everyone, please stay safe in this rather crazy times in our lives, and have a wonderful, wonderful family holiday. And we appreciate it.
Thank you, Nathan, for your input. Appreciate it. Thank you, Mike.
Excellent. Thanks, everybody.
Take care.
Good night.
Bye.